Okay, well, welcome everybody to our first of this school year's ASME Provider Network meetings. And this session will focus on asthma self-management education with applied skills to support students in self-management. And again, I'll turn it over to Dr. Kelly to start the presentation, but I did want to do a quick introduction. I'm Karen Casper. I've been moved to a respiratory health director position and support the asthma program and oversee the new COPD program. And I'm very excited to introduce Kanagavali Matavatan, whose name I still mess up a bit, but Vali, and then of course Dr. Cowan, and we'll be supported by Melissa Barron, I believe, will join us soon, an certified asthma educator. And so these are designed really primarily for school nurses, but we have a number of other healthcare professionals, health professionals, healthcare professionals, and so all are welcome. It is designed, we know you and school nurse offices have to drop things for a student walk-in, so we're recording this for that purpose, so you can follow up and look at the recordings later. This is designed to really generate discussion, so feel free at any point to bring up questions. So with that, I will turn over the mic to Dr. Cowan.
Are you actually listening or talking to someone?
Hey, everybody. I'm Kelly Cowan. I'm one of the pediatric pulmonologists at UVM Medical Center. And like Karen said, Melissa Barron, one of the pediatric pulmonology nurse asthma educators, is going to join us as well. I'd love to know who else here, if you wouldn't mind putting in the chat. And I will try to keep an eye on the chat, or we'll check back in on the chat to answer questions as we go and through the end of the discussion as well. Um, this this course series will have credits for each session, and this form is to share that we don't have any financial disclosures. Um, as Karen said, the goal is to reinforce knowledge foundation and around delivery of guideline-based asthma education for children to support better asthma control. And our big focus is on supporting students with asthma. We'll go over a broader background of asthma today as well. We want to be able to identify kids with suboptimal asthma control and be able to share asthma education with them. In this talk especially today, but in next week's as well, we'll incorporate the 2020 NHLBI guideline updates. We've been getting questions from, as we're seeing more and more of smart therapy coming into the schools. So we'll go through again today about how to use smart therapy, why we do that, why we're seeing different inhalers coming into school, and then just some of the changes we've been seeing over the past year or two in the types of inhalers that kids are prescribed is what we'll go through today. And then we'll talk about environmental triggers next week in going through an Envision walkthrough, and then nominating your school for asthma-friendly school recognition. And then we'll have time. I can stay in as long as you need today, and also we'll have time next session and then a full session to be able to do case discussion and questions coming up. Next slide. So our course session is set up, and we'll come back to this at the end too, and we're reviewing, as this first session is on asthma self-management education overview, basics around asthma, some of the basic medications and device use. And then Karen's going to go through at the end about some framework for delivering the asthma self-management education. And are pieces that you can think of as you're working with students and some of the tools that we're going to share. And then next session will be about asthma triggers and tools for trigger reduction. And then we'll have a session for case discussion questions, anything that was lingering or that you may want to discuss. And I'd be happy to, if you want to share cases, I can present anonymously and share teaching around that. So that session will be open for whatever we need for the third session. And next slide. So we can just go on to the next one. Karen. So talk about why we want to talk about this. So uncontrolled asthma in children. 1 in 12 children have current asthma in Vermont. 61% can have uncontrolled asthma at any period of time. And the issues with this become, one is risk, so asthma exacerbations like hospitalization, ED visits, but the other common things we see is missed school days. So more than 1 in 3 missed at least a day of school in the last 12 months, and some of them many more. About half of kids have had activity limitation over the past month, and about a little under 20% have had sleep disruption due to asthma. And those are all things that affect school for children. When we're thinking about, on the next slide, we're thinking about activities for asthma healthcare delivery, along with all of the management issues like prescribing medications, determining severity. One of the biggest aspects is providing routine education on patient asthma self-management. So how children and families can take care of their asthma, how to use their medications, why to use the medications, and reinforcing those skills for their learning. Next slide. So probably a familiar looking picture of asthma with airway inflammation, hypersecretion. The NHLBI defines asthma as a chronic inflammatory airway disorder. This is a disorder with recurrent or persistent episodes, variable airflow obstruction, and bronchial hyperresponsiveness to a variety of stimuli. And in children, the presentation can be really variable. So some kids have coughs, some kids have wheeze, some kids have both. Kids can be really impaired or demonstrate, risk of exacerbation even with milder symptoms. So it's really important following them over time. The diagnosis for this is based on history, especially in really young children. Objective measurement of lung function is difficult, and if tested when they're well, lung function is often normal. And there can be a lot of different triggers. They can be quite well in between triggers, especially viruses, and that can make things a bit tricky to sort out. And with infants, that's an additional challenge. There's not a lower age limit where asthma can be diagnosed. You can be diagnosed without lung function testing. But with infants, we worry about other conditions, airway conditions, in addition to asthma. So those can take a little extra time to sort out. Next slide. And we'll go through triggers and trigger reduction in more detail next week. But the most common triggers we see are allergens, viruses, environmental exposures like air pollution, tobacco smoke. One of the biggest things for kids in schools is viral exposures, and for missed school and exacerbation, that's something that keeps kids out a lot. And sometimes we work hard on keeping symptoms minimal and keeping them so they're able to attend school or recover more quickly. Next slide. It will show what's happening during exacerbation or during more airway inflammation on lung function testing. So this would be an example of an older child having lung function testing with spirometry. It's our main way that we follow lung function. And the normal airway, there's not a lot of inflammation there. With asthmatic airway, the underlying problem is this inflammation. The symptoms come from bronchospasm where the smooth muscles contract and there's either cough or wheeze or other airflow limitation there. And what we see visually on spirometry is in that first picture, that scooped shape there, we call that dip there, versus the second where things look normal. So this is what we want to try to prevent with asthma therapy. Next slide. When we're thinking about severity of the disease, that can vary over time. And what the intrinsic intensity of the disease is, that guides our treatment decisions and how to start and adjust therapy. I think the main point here would be that it might not correlate with the intensity of exacerbation. So someone can have mild asthma or intermittent asthma and still have a severe exacerbation, even though their underlying disease is mild, depending on what the trigger is or what the circumstances are. And the domains of asthma severity and also in following asthma control are impairment and risk. So the impairment for kids is the frequency and intensity of symptoms and their functional limitations. And the risk is likelihood of exacerbations, decline in lung function, reduced lung growth, and then adverse medication effects from treatment. Next slide. We follow asthma control. So that's the degree to which the symptoms and disease effects are minimized and then meeting the goals of the treatment. And after kids are on treatment, we work on maintaining control, and that helps us either keep the same therapy, adjust therapy over time. And the goals of that are to reduce symptoms, functional limitation, improve quality of life, and reduce adverse effects. And there's a number of different scoring tools to use. Karen's going to show you asthma control test, which is this questionnaire here, which will give a score, which is really helpful to track over time whether the numbers are improving. There's several for different ages. There's SEAC for younger kids. There's the asthma control test or ACT for big kids. There's track scores. So it doesn't specifically matter what people choose to use for asthma control tests as long as it's for the right age group and it's monitoring the same test over time, then you can go with your preference. Next slide.
Dr. Cowan, can I interrupt just briefly and ask whether or not any school nurses in their daily engagement with those with asthma deal with these questions of severity and or actual determination of asthma control?
No, but that's something that is part of the foundation of knowing about asthma is that
Yeah.
that typically the child will have a diagnosis of asthma, either mild, moderate, or severe persistent asthma. I'm happy to share the list of the dense tables of counting symptoms and classifying severity, but it's typically we gloss over it and it's not kind of boring to spend time on.
Yeah,
But I'm
yeah. I was just
happy to
wondering
go
if,
through those details. But the
okay.
understand the severity on our clinical side will guide what kids are on for treatment. Um, Typically what we see at school are that people who might be coming in for respiratory symptoms then getting needing to reach out to their primary care or to decide about a step up in treatment if they're having a lot of symptoms or poor asthma control. um, and that can change over time. It's something their pediatrician will assess over time, how the severity of asthma. And after people are on asthma maintenance treatment, really gauge the severity by what level of medication, how high a dose are you needing to maintain control. The thing that is important to know in asthma severity, if you back up the slides, is that the severity might not correlate with the intensity of the exacerbation. So if someone has mild persistent asthma as a diagnosis, it doesn't mean they can't get really sick. And it doesn't mean that they wouldn't have more symptoms. And if their asthma is poorly controlled, regardless of the severity, then that would need attention, whether it's a step up in treatment, management of acute exacerbation. So that's the important thing to know is that even if it's listed as mild and that's what the history has been, it doesn't mean they can't develop other symptoms. It's not always a static thing over time for children. And then Yeah, there's another question.
So it's regarding the previous slide, asthma severity. So you're saying if the symptoms are mild and then they are diagnosed and the children are diagnosed with mild asthma, so it doesn't mean they are really mild. That's what you said, or I'm just missing something here, I guess.
Yeah, so um, children can be diagnosed with intermittent asthma. So
Yeah.
those children, I've taken off the slides that people tend to not like to see, but we can come back to those and share the dense slides about how clinically asthma severity is categorized. Um, but based on the frequency of symptoms, the intensity of symptoms prior to diagnosis or prior to starting medication, then they would have a diagnosis of mild, moderate, or severe persistent asthma if they're a candidate for maintenance therapy. That can change over time. Things might be super well controlled on a medium dose of therapy for a long duration, and then we might reduce it. And their symptoms and level of therapy might correlate with what we would call mild persistent asthma. It doesn't mean that they can't get really sick. If someone comes with a diagnosis of mild persistent asthma or doesn't have a diagnosis of asthma, we see these kids admitted to the hospital for an exacerbation. It might be their first time. You certainly can have severe symptoms or more symptoms, even if you're, have mild persistent asthma or moderate persistent asthma. It doesn't mean you would never have a severe exacerbation or that symptoms should be regarded as always mild. People can get quite sick, even if their underlying level of disease is mild and they're needing a mild amount of therapy to keep things under control. So I typically categorize, the simple way to think about it is decide, when I deciding is like, do you have persistent asthma? Meaning, are you at a level of symptoms? And there are guideline-based charts to go through to determine that, where you need maintenance therapy, daily therapy to keep symptoms under control. Or do you have intermittent asthma where the symptoms are so infrequent and mild where and it's quite mild if that's the case where it's just intermittent bronchodilator treatment. So, and then when people have persistent asthma, we'll categorize as mild or moderate or severe persistent asthma. Are there other questions about that, or should we, any other questions? I'm happy to come back to that point. I think I do want to make sure we address the question that people had as a priority about getting the questions about smart therapy or um, the types of devices answered. So I'm happy to come back to that too, or we can hold this for, more discussion. And I'll make note that people might want to see those slides about how to determine severity, but that's not something that's something that children would come with a diagnosis. Um, Factors that are associated with increased risk of exacerbations or death would be when they have severe airflow obstructions on spirometry, more than 2 ED or hospitalizations in the past year, history of intubation or admission, certain demographics, and biggest one we see of non-use of inhaled corticosteroids for persistent asthma, and psychosocial factors, and then attitudes and beliefs about taking medication. And this again doesn't mean people can't be at risk of a severe exacerbation if they haven't had these things. It's about thinking through risk for each child based on their symptoms and asthma control. Next slide. The social factors that affect adherence and control. That's the main issues. There's other non-social factors, but the main issues that we see are mental health issues, substance abuse history, safety in the home. Some things that are pretty common in most households are whether there's multiple homes or caregivers, and meeting the right level of supervision for the child and assistance with medications. We often see that young children are super capable of doing a lot of things at home. You might have a school age child who's able to cook a meal, they're getting ready for school on their own, doing most things on their own, but this is something that they still need adult supervision with the schedule and doing, even though it's something that they're physically capable of doing. One thing when we see this is often reassuring parents it's developmentally normal for school age and older children to not remember well and needing a supportive adult to encourage that independence. But we do see kids who are not as independent in that regard as they are in other things in life. And I think as kids get older, they have a lot going on and they do need that additional adult guidance. Other things that are a big issue that we see are barriers to obtaining the medication. It can just be really hard. Depending on the insurance, the out-of-pocket costs for asthma medications can be quite high. And this is where having them, meeting back with their, asthma provider about medications if they're prescribed something you're not able to afford or those things, because usually we can navigate something that's reasonable or some alternatives to figure this out if we know about it. Transportation is difficult. A lot of times something is needing a prior authorization or the pharmacy doesn't have it in when they're going to get one thing and then they have to go back, and that is a huge challenge. It might get reshelved, they may not have it again. So we see a lot of delays in people being able to pick up medications. And I think those things do factor into kids getting, like, physically getting their medications to schools, which is sometimes a challenge. If they're able to get refills, sometimes for the same issue, and then, pharmacy insurance. So I think those are the biggest thing we see is supervision for kids, I think, and then the barriers to getting insurance. Other issues are families feeling comfortable with the medications. Mainly this would be an understanding why they're prescribed, how they work, what the benefit is for their child, minimizing the side effects, and then making sure it's meeting the goals of treatment and whatever the shortest amount of time, and having some, plan for when would we step down therapy or when we would consider that. And those are some ways that we help with the medication parts of that. So most of the asthma medication education goes around, understanding that and families feeling confident in using them. Sometimes we find circumstances where medications need to be administered at school. That's something that nurses also may wonder about if they're seeing kids with poor asthma control. They may wonder if things are really stuck at home and families are not able to do it, if that's something that could benefit the child. Usually we exhaust all options of being able to do that at home, and families who do have them administered at school are super grateful, and it really helps the child's asthma control a lot. We also check their medications and devices and check their refill history, because sometimes they could be using an empty inhaler, it could still be spraying, sometimes just lose track of time and don't have enough refills. So some of those factors we could figure out was just checking the refill history and, supportively addressing any, barriers to getting the medications, or if they think they had it and they don't have enough, and making sure that they got what we thought they did from the pharmacy. Next slide. For medication adherence, I think the big reason for low adherence we see is thinking that asthma is episodic and not chronic, or even having that understanding, but things have been good for a while and people do often stop taking their maintenance medications when they feel well. Sometimes that goes okay, but a lot of times for kids with persistent asthma, that does not go okay and leads to either exacerbations or more symptoms and more missed school due to illnesses. Things that we think through on that is commitment, concern, and cost related to adherence, and with the commitment that they do feel confident about the medication being important and why it's being used and how it works. Concern about medications with this really normal, and worry that there'll be side effects or worry that it will be more problem than not taking it. And then cost being about the out-of-pocket expenses for medication. And I think that's something that we don't always hear back from patients about as often as we would like. Sometimes a lot of time goes by while they're trying to figure that out, where maybe we could be more helpful. So that's something, if that seems to be a factor, we'd like to try to help navigate. So we'll move on to medications. So the treatment we have available is effective to control symptoms, reduce airflow limitation, and prevent exacerbations. And long term, we want to avoid chronic inflammation leading to airway changes and premature decline in pulmonary function. The short term, we want kids to not have risk of morbidity due to exacerbations, and we want them to be able to attend school and have better quality of life, play sports, and not have limitations on their activities. So the long-term control would be to control persistent asthma, treating the underlying disease, and the quick relief is to treat the symptoms and exacerbations. So moving on to familiar medications on the next slide is inhaled corticosteroids. That's first line. This is what you're going to see in the green zone of their action plan if they are prescribed them. And this is the most efficacious prophylactic therapy. This treats the underlying problem. The other thing it does is it upregulates the beta 2 receptor in addition to reducing inflammation. So your bronchodilators should actually work better. And it reduces airway hyperresponsiveness, improves asthma mortality rates, decreases exacerbation, hospitalization, and improves the symptom-free days. So this is the main treatment. It does require kids to take it daily. The easiest to administer, we're going to have a section in this talk about the devices. The easiest to administer is the fluticasone, propionate, and the mometasone, MDI. These are given with the spacer. And if you've seen asthma medications in the past, fluticasone was Flovent. There's not a brand Flovent now. It's generic. It's the same medication, and it looks like the same orangey, colored device. And those are mostly the easiest to administer. And we're going to go through some of the other devices that you might be seeing on your action plans as well later on in this talk when we go through the devices. But these are an example of just a plain inhaled steroid, and that's all that's in the device. And there can be varying doses based on what's the child needing to meet their symptoms. So inhaled corticosteroid and long-acting beta-2 agonist, or ICS/LABA. Examples of this are Symbicort, which is the red device there, Dulera, the blue one, and Advair, which is the purple one. And the LABA is a long-acting beta agonist. Examples are Salmeterol or Formoterol. It's a long-acting albuterol, basically. It lasts about 12 hours. And for kids whose asthma is not well controlled on just a plain old inhaled steroid, changing to ICS/LABA can be more effective at controlling symptoms and improving lung function than inhaled steroids alone, adding a leukotriene inhibitor, or doubling the inhaled steroid dose. And for kids who are pretty symptomatic with nocturnal and exercise symptoms, these are usually my go-to. And the nice thing about these is that they can be used for SMART therapy. And we will get to some examples of asthma action plans that have SMART therapy on them. So if you're having kids who are bringing a Symbicort or Dulera inhaler, we'll go through how to use that. Next slide. So we talked about the maintenance therapy, the daily, everyday therapy. Now acute therapy. So for symptoms, we often use a short-acting beta-2 agonist, albuterol, and that treats acute bronchospasm by relaxing smooth muscle and prevents exercise-induced bronchospasm. Mostly this is the inhaled route with a spacer. There are some devices that don't have a spacer, so that's something to know is what the child-specific device is. And this isn't something that should be used chronically. If kids are meeting a certain threshold of needing this pretty often, then they should be on maintenance therapy. And then inhaled steroids plus LABA. That's the next line here. This we can use for SMART therapy. So this is single maintenance and reliever therapy. And this is for kids who are just bringing one inhaler to school, and it's the same one that they take for their maintenance. So this is for inhaled steroids and Formoterol, which is Symbicort or Dulera. Other add-ons we have that is typically we don't prescribe at school, but there may be, special circumstances for this. So anticholinergics like ipratropium to be like what's in aducanumab, using this acutely, and then systemic corticosteroids for an acute exacerbation. All right, next slide. So smart therapy. This is a single maintenance and reliever therapy. And the only medications you can do this with is inhaled steroids and formoterol. So the two that we have available to do this with are Dulera and Symbicort. And you cannot do this with Advair. So if you have a child who's on Advair, they can't do a smart therapy plan. So if you're starting to wonder, like, I wonder if they should do that, they can't do it with Advair. And there are some kids who are on Advair because that's all they tolerate or insurance requires. They can't do smart therapy with it. So for kids who might need smart therapy, our ones we go to are the Symbicort or Dulera. And this is something that we do consider for kids with moderate to severe persistent asthma. It's not mandatory. So you might not see this for everyone if they're well controlled with using albuterol. But there's a high certainty of evidence in the 12 and up group and a moderate certainty of evidence in the 4 to 11-year-old age group. And we would, if you're seeing this on the action plan, we'll go through these examples. In the ages 4 to 11, the maximum that they can take is 8 puffs of Symbicort in a day, or the Dulera. And the max they can take for 12 and up is 12 puffs in a day. And the what the idea behind that is that you're dampening down some of the inflammation really early on. And you are also giving the formoterol, which lasts about 12 hours, has a rapid onset like the albuterol that lasts longer. Most kids don't get to the maximum, especially in that older age range, but that's really important to know in communicating with families if they're taking extra doses at school, how many they've had, so that the families know what they have left. So for example, if you had a 4-year-old who's on 2 puffs twice a day of Symbicort already, they're already taking 4 puffs a day. So that would mean when they're sick, they have 4 more puffs to do what they want with over the 24 hours. So families do tend to divide that up, and they may give it 3 times a day during the day and once overnight. It's pretty flexible on how to dose it. But that makes things a little tricky on the counting of how to do it. And when kids are a little bit older, most kids aren't reaching that maximum, so it makes it a little bit easier. Next slide. I think we've covered a couple of these things. You cannot do this with Advair. That's one potential issue. And then it does present some challenges for monitoring and follow-up. If we're following a refill history for bronchodilators, it's it used to be, we count how many albuterol inhalers and see how fast we think people are going through them. And that might be a marker for excess symptoms. If they're going through a maintenance inhaler more often, we often don't know, because often we will prescribe several at a time anyway, because insurance prefers that. So they can have their maintenance medication on hand. And it is harder to track refills and what they're using them for. So making sure that we're following them in clinic often enough to look at asthma control is what we do on our end, but then having parents have that awareness of when to be checking in is also important. Other issues where you might see that why doesn't this child have this on their action plan, if it might work for them, is it may be an insurance limitation as well. So sometimes for practical reasons, if their copay is much higher for the ICS LABA, so if their Symbicort's a lot more expensive than albuterol, and albuterol is working great for flares, then we would just keep them on their albuterol for flares. So that is a bit of a challenge. If kids are doing much better on the smart therapy and families can swing it to pick it up a little bit early and stockpile some, we can do that. But there are kids who have a dual plan because they may have albuterol at school because they can't, insurance wise, we can't swing it to have extra. When kids are using a Symbicort inhaler, or a Dulera inhaler, if they're taking 2 puffs twice a day, their inhaler is going to last 1 month. So if they're taking extra puffs for exercise or for activities or for sickness, they're going to go through it a lot faster. So that's why they would have to be able to have coverage of medications. For kids with Medicaid, they do cover really well. So that group of kids can get smart therapy covered much more easily. Other insurance is a bit variable in that the family usually gets some options on treatment, and then while they're figuring that part out. Next slide. Just add a little here on, we're not going to go through all maintenance, all asthma medications exhaustively, but the common medications as an add-on for maintenance, leukotriene receptor antagonist, montelukast being the most common, has an additive effect with inhaled steroids for some kids, less effective than inhaled steroids overall. So it's not the first go-to, but you may see this on some kids' action plans. We do go over the families that there's a risk of behavior and mood side effects. About 3% of kids is what that's listed as. It goes away really quickly if kids stop taking it. But that's something we do have to counsel families about, is if they're having mood troubles, then they should stop taking it and let us know that they're no longer on the medication. It will go away quickly, but that's something to be aware of. It's certainly not the cause of all behavior issues in children, but it's common enough that we don't continue to give it if that's the case. Next slide. So exercise-induced bronchospasm. This usually shouldn't limit participation in activities. So if your kids are having a lot of exercise symptoms and benefit from pre-treatment for exercise, we can adapt their action plans however works best for school. So I don't mind being reached out to switch the plan to have that scheduled if it's easier for the child, or if it's written as needed. I think we found in our office it may depend on the school and what works best there, of how to write that, and then how, what works for the family. Most younger kids don't always do the best in advocating for themselves when they need it, because they usually look okay, and that it often is easier if they really benefit from pre-treatment to just have that built in their plan to go ahead and pre-treat before. Some kids have a predominance of exercise symptoms and do qualify for maintenance therapy based on the frequency of those symptoms. So if kids are having frequent symptoms that aren't well controlled with albuterol pretreatment, or it's really frequent, I would use maintenance therapy for that too. So it's not just about how kids do with illness or other symptoms, but some kids do need a daily treatment with inhaled steroids or ICS/LABA for exercise. Slide. So I like this slide a lot for this picture, a lot for teaching. I think I use this one the most in clinic for teaching about how medications work and what's happening during symptoms. And I think this has helped me be able to describe better to families why we're using medications and what's happening when they have certain triggers. So we have it first on the normal airway, and then we have in the middle that airway with asthma, and that's where the underlying problem is, with the wall inflammation and thickening of the wall. And this is where we do often see kids with lingering illness, chronic cough, recurrent pneumonias, having, chronic, when those things are due to asthma, then this is what's happening. And that very quickly gets kids to asthma during an exacerbation, where there's even more mucus secretion, there's more wall thickening, those smooth muscles are tightened up, and then you have air trapping in the alveoli, so they can't exhale fully. So trying to breathe on top of filling this full balloon and can't exhale fully, so they get very short of breath, and they could have cough or wheeze or both, depending on how tight things are. And where the maintenance inhaled steroids work is on that inflammation to make that more normal. So, and then also improve the response to bronchodilator. So when that should reduce the chronic symptoms and then reduce the acute symptoms as well, and reduce the need for rescue medication. So I think this, there's other tools. Some people have a model, or some people like to draw what's happening with the airway, but this could be one tool that to use with kids or families, of what's happening and how do the medications work. So where the inhaled steroids work to keep things more normal, and then where the bronchodilator works, either the long-acting bronchodilator or the short-acting bronchodilator, to relax those smooth muscles to relieve symptoms. Other things are thinking through triggers, thinking through environmental factors. how to monitor for symptoms, understanding their symptom perception. Is it a kid who doesn't know until they're really, really sick? Or is it a kid who notices right away? I really want kids to have great asthma control so that they know when they don't feel good, that they're not living with low lung function and a lot of inflammation, just not knowing that they don't feel well. And that can be dangerous for kids, especially as they're getting older. And this can help families to agree on treatment goals. Like, what do they want to get better? Are we looking for reducing severity of illness or improving exercise symptoms? What are we looking for? Next slide. So I'm going to go through next some multiple examples of asthma action plans. So this, when we do these in clinic, I feel like these are a nice way for me to go through and write it with the family so that we're all on the same page of what's happening in the green zone, yellow zone, red zone, and we can modify the medications if they've stopped taking something or if we need to increase the dose. And this is a good time when I go through it to discuss, well, when are you in the yellow zone? How do you know? Sometimes it's if they start coughing. Sometimes for some kids, it's if they get a little sniffle, then they're there. And this is a good time to review goals of it. And then they should have copies for home, school, daycare, and then prescriptions for the same. So next slide. Sorry if these all look the same, but they're all a little bit different. We'll just go through that. This might be something that you're seeing is that some of these plans look similar, but they're done a little bit differently. So this is a teen that's transitioning to smart therapy. So an example would be like, family's not sure whether they want to try that because albuterol's always work, but they want to try it, or they're not sure whether insurance is going to cover it, but they like the option. And in this case, they have Symbicort that they're taking twice a day in their green zone, and then they don't take anything prior to exercise. And then in their yellow zone, they take Symbicort every 4 hours as needed, and max of 12 puffs in 24 hours. Or they can take albuterol every 4 hours. So this would be an example of why would you maybe see more than one thing on the action plan? And I would be okay with them having just one of those at school, whatever it works out to. And I do try to offer to families I can, clean it up and take one off, later if they're not doing both options. If they're just going to Symbicort, we can take off the albuterol option. But this would be an example of somebody who either for insurance reasons or the family's just not sure what they want to try, have both on their plan. And then we can go to the next slide. And then here is another example of smart therapy for a teen. So you'll notice that they're just taking Dulera, and they're taking it as needed for sports, and then they're taking it as needed for illness also. And this is someone who's just having the one inhaler. So you would expect that this child would have the Dulera either at school with the nurse or would be self-carrying that. So one or the other. And you'll notice that they have a max written on their plan of how many they can take. I'll do the next one. So this one, this one's written a little bit differently. And I think that, as nurses, you can see for your students, if it's written in a way that is not helping, if it could be written differently that's more helpful, that's fine to reach out about. This is an example of something you might see that this child is using in the yellow zone, 1 to 2 puffs of Symbicort as needed. This is it's not a child, it should be a teen. This would be a teen child if it's 12 puffs in 24 hours as their maximum. But the actual dosing for these in Yellowstone, it's a little different than the albuterol. The albuterol we usually have on a every 4-hour schedule, right? But for the Symbicort, you really can do this as needed. And the idea is you're taking it as needed, and if symptoms are ramping up, you'll get to your max. That makes it a bit of a challenge to know, well, when would we switch to something else, or what would we do? So I think some of us, using it this way has worked for a lot of kids, for the as needed and checking in with their parents. If for some children you're noticing they're coming in a lot for it, and it might be easier to have it noted every 4 hours or something more as a marker of I probably should check in with someone about it if they keep coming, that would be also okay too. But I think for understanding the mechanism of how it works, the Symbicort can be given as often. There's not a specific time frame that you have to wait X number of hours between giving it. Families often ask, well, what would happen if I get to the max? Okay, and this shouldn't, hopefully is not something you encounter at school, but it could be if you encountered it, they've been taking it all night frequently, and now they're at school, and the parent has said they've already had some. And that in that case, then they would be calling if they've met the maximum, and we would switch to albuterol. And for some kids, that would mean they need to be seen if that's not something that they have at home because it hasn't been in their plan. But that's what would happen, is that in their course of care, if they're needing urgent care, if they're needing their pediatrician, or if they're needing to go home and switch gears, then it would be switching to albuterol. And so what you tell patients, if it's they've met their max, partway through the day or in the evening, then they need to call to let me know, and we would make a plan to have them seen, decide where based on the time, or decide whether they're starting, an acute plan with oral steroids and then switching to albuterol so they have something. So there are moves we can make after that. Most kids don't get to that, but I want to bring that up as something that can be a bit confusing with this plan. I think it's fine to treat it like, if they were needing too much albuterol, or it's seeming like it's not going very well, like they're coming back, then that's the time you would already reach out anyway. And you can treat that similarly with the Symbicort. If they're coming back for it often and it's not touching their symptoms, or things are getting worse, it doesn't matter if it's short time frame, then that would be an acute time where the child would need their care escalated. Okay, so we can go to the next one. Okay, one more, Karen. Although we had a lot of these. So they can look a little bit different. We'll just end on this one, and we can skip over the next one, Karen, but I just wanted to, review that. I think when you're looking at action plans for kids who are bringing in a Symbicort inhaler for their rescue, they should have what their maximum is written on their plan, and how many puffs tends to work for that child. And I think that the other point would be that the plans can look slightly different, but the goal would be that they're able to get something as needed. And that just like with the albuterol, if you were seeing that this isn't going super well, it's not working for them, and they're needing more doses, then that would be a time to figure out their next step in care, whether their parent needs to see them, whether they need something more urgently. And then we can skip 2 slides. Okay, so let's go to the device types here. And this is something you guys can put, let me know in the chat as we're kind of winding down on time, because we're going to have some extra time with the session next week. And we can spend some time looking at these videos of these devices. And I'd like to know maybe if we can prioritize certain ones that you're seeing. So we talked before about the most reliable being the HFA MDI, like the form of Flovent, like the fluticasone MDI or Symbicort that you use with a spacer in a mouthpiece or a spacer in the mask. And we're seeing over these last year or two other ones that are increasingly required by insurance for kids. And that might be a Respiclick inhaler, a Respimat, a Flexhaler, or a Discus, Quizhaler, ReadyHaler. You can go to the next slide here, Karen, with this. And this slide covers pretty much all of the things that are out there. We don't use all of these medications, but you would be able to find what category, if the child had it, or if it's written on their plan, well, what do they have? What is this? And And that can help know, well, what kind of device is it, and can make you think like if their technique is good. So if you have someone with an albuterol inhaler and a spacer and they're doing great with it, but you're seeing an unfamiliar looking inhaler on their green zone, especially in a young child, that's something that makes us raise red flags if we're seeing their kids' asthma is not well controlled, that maybe reviewing the device technique with them and making sure that it's actually going in like we think, because a lot of kids are getting switched just based on what their insurance covered, and it may not be ideal for their age, or they may need a lot of extra instruction to be able to swing it. We have videos from UVMMC and VDH for use of the spacer and mouthpiece, which is probably the most familiar for everybody. And then I do like using other institutions' videos that I found helpful. The company websites have them. And the Boston Children's YouTube has them for, I think, about every device I've found. And I have some links for that. And I found it really helpful for myself because there's sometimes I haven't seen one of these in a long time, or they've updated it and it works a little bit differently. And it's been an eye opener. I'm going to go through this with families with the videos and use these. And it can be easy when kids are well trained, but without that, or without assessing whether this is going to work for them developmentally, then we don't know how reliable these are. Let's skip down next one, Karen.
Dr. Khan, it's 4 minutes, so just dividing between a question or continuing. We have time next week to incorporate.
We do. And would anyone like to pause and ask some questions or share what you might like to hear about when we have some extra time next week about devices? I think that would be fine. Is anyone seeing other devices on the green zone, such as like QVAR, Pulmicort? Anyone seeing some of those on the action plans? You might just see the name of it. You may not necessarily see the device because they may not be bringing those in. And then how about questions about smart therapy? Does anyone have questions today, or do you want to think about questions and feel free to send those and I can pick some, things to go through from that? Does anyone have questions today?
If not, Dr. Cowan, which any of these last slides that you want to pop to, or you want to end it here?
I think what I would do is, I guess I had a question on the smart therapy for you guys, going into what we might go over next week. Is anyone seeing it? Seeing a lot of providers putting smart therapy on the plans, or not seeing it? Or a little of both?
I think Dusty, you're muted. If anybody's sharing, make sure you unmute. Okay.
I think what we can
no
look at, Karen, is we don't have to look in here, but I'll just go down to slide 39. We can go through, you can feel free to send to me or to Karen if there's specific ones you want to start with. We could do a couple of these next week these are the Boston Children's YouTube of showing a child, like an age appropriate child, using a couple of these other devices to get a sense of what's out there. it may not be something you encounter, but it may be more something that if they're coming in a lot further albuterol and they have this something on there, going over their maintenance device or what they're taking for that can be really helpful in figuring out what's going on. So we'll save those to go through. And then
That
I
sounds
think, Karen, if you want to give a preview for
Yeah.
teaching.
Yeah, next week we'll, like Dr. Cowan mentioned, we'll cover triggers, but in that conversation, we'll also look to issues that relate to then flare-ups or uncontrolled scenarios where supporting removal of triggers is important through Asthma Friendly Schools program, and possibly ASME delivery, supplementary education beyond what Dr. Cowan mentioned, where you go a little more intensely around areas they're having trouble, and we'll cover that. And it counts as points for the recognition of Asthma Friendly Schools and the Envision walkthrough and a couple of other criteria that we can look at next week as well. So we're at time. So I want to thank you all for joining us this first session, and we look forward to seeing you in the second section next week. This is only a 3 blast series, and then we'll do again another 3 blast series in January. So we're trying a different model, and that'll be a different time frame in January, just trying to find things that work best for you all. At any rate, wishing you happy holidays and season, and enjoy this, and see you next week. Thanks so much.
Thank you. Bye-bye.
Thank
Bye-bye.
you. Bye.